बड़े बंद। A very good evening to one and all. I heartily welcome all the members of API, ICP, PRF, and other association members, delegates who have joined on this occasion. I welcome our senior most guest of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS, and Distinguished Professor, KBN University. I welcome our today's chief guest, Dr. Jyotirmay Paul, President, National API from Kolkata, a dynamic personality who has taken national API to an international level. I also welcome our other guest of honor, Dr. A. Muruganathan, who will be joining shortly, the Director of PRF, the past President of API and the Governor, ACP Governor India Chapter. I welcome Dr. Kamlesh Tiwari, the Dean ICP from Muzaffarpur. I also welcome Dr. A.N. Rai, Founder President of CCDI from Gaya. I welcome Dr. Pragya Yadav, Director and Scientist of NIV Pune, a great academician and a researcher with many publications, both national and internationally. I welcome our today's dynamic speaker, Dr. G.V. Rao from prestigious Institute of AIG Hospitals and Research Center, Hyderabad, headed by world-renowned gastroenterologist Dr. D. Nageshwar Reddy. I welcome our today's moderator, our own faculty, Dr. Murali Mohan, a great researcher from Narayan Hospital, Bangalore. I also welcome Dr. Kushal Das, Distinguished Chair, Professor BLD University, Vijaypur, a scientist. I welcome Dr. Vinod Ravindran, rheumatologist, a great researcher from rheumatology field. I welcome our own organizing team headed by Dr. B. Malingappa, Chairman API Karnataka, is Ravi Kirti, Vice President, Srinivas Murthy, National API member, and Dr. Suresh Sagrath, past Chairman CSI and API Karnataka and Faculty Council member. I welcome all the delegates who have joined from all over the country, making a national event which COVID-19 has taught a new normal life. Let us not waste time by reading their CV profile. Let us read and hear and learn from them. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
We are virtually honoring all the faculty as well. And now I request Dr. P.S. Shankar for your introductory remarks.
Dr. Rao, distinguished panelists, dear colleagues and friends, we have assembled here for an update on the research and innovation. Earlier, during the last century, research, especially the medical research in India, had been carried out by individuals. Some of the examples are Ronald Ross, who carried out his work on life cycle of malarial parasite in Secunderabad and Calcutta. And he got Nobel Prize in 1902. And he was the second person to receive the prize after its institution. Other notable research like Himalayan endemic goiter by Robert McCarrison, urea sivamin for the treatment of Kala-Azar by Upendranath Brahmachari, use of Rauwolfia serpentina in hypertension by Rustum Jal Vakil. He was the first Asian to receive the Lashkar Award, which is considered as the next to Nobel Prize, and J receptors by A.S. Pental, and even Marsilea minuta which is used for the treatment of convulsions by none other than Asima Banerjee, who was the first lady to receive the PhD in our country. And the institutional work by Tuberculosis Research Center on domiciliary treatment, intermittent chemotherapy, and short course chemotherapy for tuberculosis. In those days, many of us as individuals carried out studies in medical colleges on incidence, clinical features, and management of many diseases. Later, there was introduction of new gadgets for diagnosis and studies were published on the use of new instruments. And now the research has become a teamwork involving one institution or many institutions across the country. Medical research in India is spearheaded by the Indian Council of Medical Research, which coordinates and promotes research across numerous national institutes like National Institute of Virology, National Institute of Nutrition, to name a few. And the key focus areas include viral diseases, tuberculosis, and vector-borne disease, along with growing research in the non-communicable disease and the public health. The healthcare system across India has witnessed a phenomenal change during the recent decades. Besides these improvements, it is time to lay more importance on applied research for increasing technological advancements. Our research topics steadily and greatly lack the innovation in the technological advancements when compared to the West. Now, the medical research has evolved from the individual expert described opinions and techniques to scientifically designed methodology based studies, and that is protocol based with predefined steps. Shortage of time, busy clinical and laboratory and service schedules, shortage of necessary equipment, lack of familiarity with the statistical methodology, limited training and experience in data analysis are a few problems ailing in our research. There is an added hurdle of poor financial support, limited access to the workshops on writing grant applications, inequitable release of time from the teaching responsibilities, and difficulty in maintaining the equipment are some important barriers to the research. In an analysis, the Elsewhere publication found that India's contribution to the health sciences is 3.5% and medical specialties was 4.3%, which is relatively low. The poor performance of the medical research has more serious repercussions as it affects the health of the people directly. There should be a commitment and a passion for research and innovation, an interactive and integrative environment that promotes and sustains collaboration between the clinical and the basic scientists and the technologists, and good training of the medical students in the clinical research. India should have its own priorities of research which are relevant to our problems, and the quality and the quantity of methodical and the pertinent research needs to be scaled up. Medical research and innovation are the scientific and creative processes of the advancing knowledge, and medical innovation is the creation and adoption of the new ideas, processes, and technologies to improve the healthcare. India's research and innovation ecosystem is witnessing strong momentum aligned with vision of the Vikasit Bharat at 2047. Government is fostering a knowledge-driven, forward-looking initiatives reflecting India's commitment to becoming a global hub for science and technology and innovation, driving sustainable growth. Current program has been well conceptualized and leading personalities are taking part in it. I am happy to join in this inaugural program and wish the program all success. Thank you.
Thank you, sir. Thank you for your kind words. Our API President Dr. Jyotirmay Paul is in another meeting. He will be joining shortly. Now I request Dr. Abhay Narayan, AN Rai.
Thank you, Dr. Sangram Radha. I would like to thank you for giving us the opportunity to CCDSI. On behalf of CCDSI as a former president, I welcome all dignitaries of API, ICP, and all speakers. I think here in India, we have got enough clinical material, but we are lacking basic research. And we should now go for basic research because you have got all facility for investigation. So we should start, and API and ICP and CCDI should take a lead. We, as a CCDI, decided to have work on basic research, and Dr. Arvind Gupta from Jaipur has been given responsibility to select the topic. The first topic we were thinking is sarcopenia, because it's a vital topic and basic research on sarcopenia. So I will request all other associations also to take a lead. Thank you very much. Once again, I thanks.
Thank you, sir. Now we move on to the scientific session. I request Dr. Murali Mohan sir to take over. All the faculty have been introduced. Over to you, sir.
आज क्यों नहीं आ रहा?
Good evening, one and all. It's a very important topic that we are handling today. The concept of research, which has largely been missing in our country. We know that, Indians are great clinicians. Every single person that you come across is generally an expert clinician. But that does not translate into research. It does not translate into publications, and therefore has very little impact in the long run. So today's update on research and innovation, organized by the API, the ICP, the PRF, the CCDSI, is meant to handle this question. So I'm not going to introduce speakers again. Dr. Sangram Biradar has already spoken about this, but we'll invite our main speaker, Dr. G.V. Rao, to talk to us on this topic. He will be talking on research and innovations in medicine in 2025 in India. Dr. G.V. Rao, over to you, sir.
Can you hear me now?
Yes, sir.
Yes,
We
sir.
can.
Thank you so much. Actually, I feel humbled by this invitation. I feel humbled standing behind the entire
आवाज क्यों नहीं आ रही है?
community of.
इसको हम एडिट करके फिर दोबारा.
Am I not audible?
Yeah, you are audible.
You're audible.
Yeah.
Dr. Rai, sir, can you mute, please? Because I think there was some background noise from there.
ಮುಗೀತು. I close ಮಾಡ್ತೇನೆ.
Carry
I
on,
feel
sir.
humbled to be talking before the elite physician community of Karnataka. I thank all the presidents of the societies, the executive committee, and Dr. Sangram Biradar in particular for asking me to address this elite gathering. Thank you so much once again. And this is the second time I'm coming online with this group, and I'm really humbled to be talking to you. I think Dr. Shankar has summed up the entire talk very aptly. I don't think I have to do any more talking. He has given you beautiful statistics, what is the status of the research in India, and what we are likely to do in future. I would like to take you through the journey, our journey at AIG Hospital, which we have been going around for the last 3.5 decades. And a lot of passion, which we started doing in addition to clinical work, some research work has been done at AIG hospitals. And I would like to share with you what has been happening and what has happened in the last 3.5 decades at AIG hospitals. Dr. Sangram is well aware of this. Actually, I think he must have listened to one of these talks and he asked me to do the same thing before this audience. Thank you very much once again. Hippocrates was the greatest physician and surgeon of the years. He was a clinician, scientist, and a researcher. Now, research has taken a current day clinical practice, and future of medicine is basically based on research. And the highest honor that is bestowed in research is the Nobel Prize, which is instituted in 1901. And this was shared by the greatest scientists of the years, who are all clinicians and surgeons. Somehow there is a decline in the clinician scientists, surgeon scientist species over the period of time, possibly facing an extinction. It is something like we see these species which are becoming extinct over centuries, and it is likely if this trend continues, we'll have the vanishing physician scientists in the period of time. So this vanishing ourselves into research. This is basically because in the entire medical curriculum, research has taken a backseat in our current day medical teaching and also practice. And the translation of this is that obviously the clinicians of India and the surgeons of India are missing a road to the Stockholm, where usually the Nobel Prizes are conferred on people who deserve this. Research does not mean essentially working with test tubes or looking into the microscope. There are different types of research that we do in basic science, translational research, knowledge translation, clinical research, population research. All these are types of research. I'll not go into the details of this, but we have different types of research that we practice in current day clinical practice. And what happens is whatever we do in research, it has to go through several of these things, including randomized control trials, and ultimately we get systematic reviews in evidence-based medicine, and it becomes the standard of practice in clinical practice. Unfortunately, this clinical translation is very, very stringent. You do so much of research, only part of the entire thing gets translated into clinical part, most of which goes waste, and you can see the amount of finances and energies that are wasted doing research, because only a small amount of the entire research gets translated into clinical value. And there are several types of evidence-based medicine. I told you about evidence-based medicine that we commonly practice, but there are also other types of evidence-based medicine, like people believing in religion, people believing in diffidence, nervousness, confidence. These are all different types of evidence-based medicine. I'll share you a couple of examples of this actually. I'll show you the evolution of research at AIG hospitals over the last 35 years, both at the Somajiguda and in the new hospital at Gachibowli right now, which is done under the Asian Healthcare Foundation. Now, patients with advanced malignant obstructive jaundice who are not fit for surgery or who are planned for surgery, they undergo preoperative biliary stenting. This is the patient with tumor. You can see the tumor here. We put in this metallic stent inside. You all know that actually. Then the patient jaundice comes down, and subsequently there is either palliation or he goes for surgery. Unfortunately, we have two types of stents actually, metallic stents and plastic stents. When we started our practice way back, almost about 3-4 decades back, these stents were available, but they were at a huge price. The plastic stent were almost costing about 15 to 20,000 rupees, and the metallic stent was just coming to clinical practice. The question that we asked ourselves was, can we design our own stents? And the result was this. I went to the hardware shop, picked up this meters of tubing that is available in the hardware shop, designed our own stents, both double pigtail stents and 10 French stents, using the Teflon tubes that are available from the market. So these were able to secure in meters, and then we used to cut them into pieces and then mold them, design them to double pigtail stents and the straight stents. These are absolutely similar to the commercially available ones, and the price was almost about in few rupees. So we started using this, and in fact, a lot of centers across India started using this till the commercially available stents were actually cheaper. Now, we were using different types of material, but the stents were getting blocked. So basically, you can see that these are pancreatic stent that is put in, the stent is blocked. And then we subjected this to electron microscopic studies to see what is causing. And it is basically the type of material which is causing a biofilm inside and causing the stent to get blocked. So then we went ahead and did animal experimental work on monkeys to see which type of stent is best suitable for humans. So we put stents of different material in this and sacrificed these animals after about 8 weeks. And subsequently, we found that this is the only PTFE stent is the only one which is absolutely apt and that can last longer without causing blockages, and it has got the least reaction to the thing. And as of today, these are the stents that are used in clinical practice. Now, many of you would have seen patients in advanced esophageal malignancy. Actually, this is a historical picture wherein no treatment was available. They put a plastic tube between the cervical esophagus and the stomach here. You can understand the patient had a mid-esophageal growth, advanced growth. So they put a tube connecting the esophagus above and the stomach below. This is how patient used to get palliated. Now, this sort of subsequently, when it came, actually, we started in initial part of my practice, I started putting in a lot of this feeding gastrostomies. Now, the urge to eat these was so intense that these patients used to chew the food and spit it into the tunnel that is attached to the feeding tube. Such was the intense desire to eat. And the options available were these commercially available stents, which are very, again, costly. Those days, it was costing almost about 50 to 60,000 rupees per stent. These stents were put in across the obstruction to relieve obstruction so that the patient can eat normally orally. Now, because these stents were expensive, we designed our own stents from the Morse bobbin tube in a local, under a local lathe machine. We took the help of an engineer, mechanical engineer, and designed this stent. We put grooves here so that the stent, once it is put in, the tumor grows into the grooves and it does not migrate. And then subsequently, we tested this in canine models to make sure that these stents do not cause much reaction to the patient. So we did this and then subsequently sacrificed these canine models, and we found that these are absolutely very good and they did not cause any reaction to the patient. And subsequently, these were the stents that were uniformly used across the country. Many centers used this, not only our center. This is one of the papers which was published to show that these stents, when they were put in, costing few rupees actually, they were able to palliate the patient of dysphagia and the patient had good quality of life. And then again, we had this lot of these patients with peripancreatic fluid collections and walled-off necrosis. We started putting this self-expandable lumen-opposing stents, and these have become a standard of practice. Again, the currently available things were very expensive. So Dr. Reddy has designed this Nagi stent. This is comparatively cheaper compared to the currently available stents. Now, it took a lot of time. It took almost about a decade to design this stent, and it has gone through multiple design changes, and ultimately it was tested in porcine models and subsequently came into clinical practice. And so many design changed, and then we had the final prototype which came in 2014. And we started using this in clinical practice for treatment of patients with walled-off necrosis and peripancreatic fluid collections. And it has become the standard of practice in clinical gastroenterology as of today. And it is one of the popular stents that is used in clinical gastroenterology for treatment of peripancreatic fluid collection. Likewise, I also worked with this Boston Scientific. Not all research is very, very successful. Actually, Boston Scientific designed this balloon catheter with an RFA cables which are impregnated onto the thing to see if it can be used for patients with cholangiocarcinoma. I made umpteen number of trips to US actually to check this in the porcine models. Actually, we worked on this. We thought this will come into clinical practice, but somehow this project was shelved. We used a lot of energies, both physical and financial resources were wasted in this, but ultimately it did not go to the FDA approval because of some reasons, though the entire project has to be shelved. So not all research that is done gets translated into clinical practice. And if you look at evolution of surgery, it started from big incisions to multiple incisions in laparoscopy to single incision surgery to nose scar surgery, that is the endoscopic surgery. Now, when we started a practice, actually in 2003, because we were doing a lot of endoscopy practice. Just to make mockery of us, somebody posed a question in the national conference: is endoscopic appendectomy and cholecystectomy a far-fetched dream? This, I thought, is more a mockery towards the department. They asked us, asking a provocative statement. So I had to look into this, and then actually I took a cue from this movie called Matrix, which showed that the alien gets into the body somehow, but this alien that gets into the body is removed from the body without making an incision. You understand, this is a science fiction movie which shows it is possible. Taking a cue, I took onto this hen model for the first ever time. This is actually, we picked up, because those days we did not have much access to the labs and all. So we went and picked up the hens from the shop. One of our endoscopy technicians went up, studied the anatomy of the chicken model very well. Actually, subsequently did this endoscopy in the chicken model. So we put an IV line for this chicken, intubated this, and then used a standard flexible endoscope, did an upper GI endoscopy in this, made a hole in the stomach. I got into the peritoneal cavity and with a biopsy forceps taken a liver biopsy. So all this without making an incision on the abdominal wall, and subsequently dissected the cystic artery and the cystic duct, did cholecystectomy in this hen model, and this hen model survived. So to show the proof of concept that endoscopic appendectomy and cholecystectomy can be done, I did this experimental work on the hen models and published this same time in 2003. Subsequently, we also went on to do a lot of procedures like gastrojejunostomy, cholecystogastrostomy, liver resection, pancreatic resection. All these done were in experimental models to gain confidence of movement of the endoscope in the peritoneal cavity. We did the first ever transgastric appendectomy in the world in 2003, and we showed it to the world that endoscopic appendectomy and cholecystectomy can be done. So here we have a scope that is making a hole in the stomach, dilating that hole, and then going the scope into the peritoneal cavity. And this is the thing, actually. You can see this. We are using a hot biopsy forceps to dissect the mesoappendix. And once the mesoappendix is dissected, the base of the appendix is ligated with an endo loop, and then subsequently use a snare to cut this appendix. And at the end of the procedure, we do the irrigation of the right fossa with povidone-iodine, make sure that the stump is clear, and then the appendix is removed through the mouth. And the same thing we did for the gallbladder, cystic artery duct dissected, clipped, and we removed the gallbladder. Showed the world that endoscopic appendectomy and cholecystectomy can be done. Subsequently, umpteen number of publications came from across the globe, and Time recognized as this one of the biggest revolutions in surgery, and they covered this in the Time magazine. And subsequently, I worked with the industry umpteen number of times. Again, I had to go to US to make different scopes for this purpose. So we worked with industry actually, so that I told them the idea, and the designers gave me this idea in 2004. You can see this is a drawing made in 2004. They told me that you need a scope like this with multiple channels, which can pass through multiple instruments. So we worked on this. So we had this scope with multiple channels. You can see this multiple instruments going through channels across the thing. And people made mockery that they're trying to do procedures like this. And they also drew cartoons of myself saying that I'm trying to do something unbelievable. Subsequently, we had these 4 types of scopes that came into prototype. You understand, these are scopes with multiple channels, and we thought this would make a big impact in clinical practice. But same time, actually, laparoscopy started coming into a big way. Actually, this 2003, 2004, actually, laparoscopy was emerging specialty. And I feel that actually it is the laparoscopic market and the industry which put these scopes on the shelf. They did not allow these things to come onto clinical practice. So the entire practice of natural orifice transcapular endoscopy took a back seat because this was shelved. But we continued our research. Actually, this is my mentor, Professor Sidney Chung, who is a laparoscopic surgeon, who sitting on a breakfast table with us drew this diagram of a robo. You understand? If you're looking at the crab, you drew this drawing of a robo, and this got translated into clinical practice. A prototype was designed by the Singapore University. Actually, you can say this. So basically, it means actually we attach these miniature arms which go through the endoscope, and we have a surgeon sitting in a console operating like the conventional. Now, this again was done on the humans for the first ever time, and we had a big editorial which carried by Rob Hawes, which said it, though it's a small series, it's a giant step for endoscopy to get into advanced practice. So these ESD procedures which are being done right now, we showed it feasible to be doing it with this robotic instrumentation in 12. Likewise, bariatric surgery, you all know about it, different types of bariatric surgery like banding, gastric bypass, biliopancreatic diversion. All these are practice, and it also showed that they started correcting diabetes in these patients. This is basically because the entire food is getting bypassed from the small intestine, and a lot of research has gone in to see why this is happening. And they feel that the basic scientists have told us that this is basically because of an imbalance between incretins and anti-incretins which are there in the duodenum. This led to the device and thinking that suppose if you bypass duodenum somehow, so suppose you put a sleeve like this in the duodenum, the food directly goes through the sleeve into the distal small bowel. The food is avoiding contact in the duodenum here, and this can correct diabetes. So this was done in rat models, and it has shown phenomenal result that it can correct diabetes in this rat model. So this led to the device, this we have been practicing at the AIG hospital. We put this endo sleeve, you understand? The sleeve, you put it endoscopically from the pylorus here into the duodenum, into the proximal jejunum. So whatever food you take, it bypasses the duodenal contact, it goes directly into the jejunum, and this has given us remarkable, that initial results were very, very encouraging. There were some small complications because of the sleeve migration, but this is getting refined, and that we'll get a refined model very sure. The other modality that has come to treat diabetes is called as the duodenal mucosal resurfacing. It is believed that if you resurface the duodenal mucosa distal to the papilla using different modalities like RFA or electroporation, this can cure diabetes basically again because you're treating, there is the imbalance between incretins and anti-incretins is being taken care of. This is the one which is going through the prototype testing right now at AIG hospital. And I think maybe from now, this will be available for patients so that patients with diabetes can be treated with these methods, avoiding treatment with oral hypoglycemics or insulin. Now, this we have shown that actually very beautiful data to show that it controls, get the glycemic control in control. Actually, still we started doing this. I hardly knew any difference between rat and mice. Actually, rats are bigger, mice are smaller. Actually, if you want bigger gastrointestinal system to be dealt with, we have to deal with rats instead of mice. And this is the DMR, duodenal mucosal resurfacing, that is done using hot water electroporation. Different techniques are used, and it is shown that glycemic improvement occurring in this patient, and it is well maintained. Islet cell transplantation is other modality that is being practiced across the world. There is autologous islet cell transplantation, that means no immunosuppression. So for the patients undergoing distal pancreatectomy, we can take out the islets and give it to the same patient. But allogenic transplantation requires immunosuppression. Now we started doing islet cell transplantation, autologous, and AIG is one of those centers in the Asia Pacific region and across the globe to be doing this procedure. Now the question that we asked was, can islet cell transplantation be done without immunosuppression? That is something like a bioartificial heart, like we were talking about a bioartificial pancreas. Again, taking a from this movie called Spider-Man, we went ahead and had a permission from the government of India, and the government of India has given the permission. So we did distal pancreatectomy in these non-human primates, and then isolated these islet cells, purified them, put them in a device called Therasite. This is a device called Therasite. This device allows nutrients to pass through, but it does not allow immune cells to pass through. So subsequently, we loaded this Therasite with these islets and put it on the thigh and the back of these monkey models, and then did both autologous and allogenic transplantation. And surprisingly, we maintained them for almost 1 year in the labs here, the NIN labs here. And subsequently, we took out this Therasite here. And then you can see this, when we subjected them to histopathology, all these allotransplanted islets were viable, functional without immunosuppression. And in fact, they multiplied in the Therasite. And this was the first ever publication we showed that islet cell transplantation can be done in non-human primates without immunosuppression using this device called Therasite, which allows nutrients to pass through but does not allow immune cells to pass through. Now, subsequently, we were almost about to start the human trials in this. This company, which is making the Therasite, went out of market. We thought we'd be able to do this and also maybe put this Therasite into the third space and then maybe treat diabetes actually. So diabetes was a medical disease, became surgical disease with the advent of bariatric surgery. And we thought, and it's becoming an endoscopic disease right now. And in future, it is likely that you can put the same Therasite into the third phase to treat this. But this went out of market, and then we in our own department started designing our own thing right now. This is the Therasite that is designed exclusively in AIG hospital, tested in animal models, and shown that it can do similar things like the Therasite I showed you. This is a macro encapsulation, and this has proved to be very good. We have submitted our project to the Government of India. We are awaiting their approval so that once they approve it, we can start doing this in clinical practice. The other question that is constantly asked in science is, can science reverse fibrosis? You're talking about chronic pancreatitis, you're talking about liver fibrosis. Can we reverse fibrosis? Science fiction movies have shown that we can reverse fibrosis. Actually, our own team, Dr. Roop Jyoti Talukdar from the Basic Science Research, he's a pancreatologist actually, who has designed diet and using fluorescent probe showing fluorescent techniques, and he's shown that he's induced fibrosis in these mice models, and subsequently used a special drug which is a combination of anti-inflammatory and antioxidant molecules. He is able to reverse fibrosis. Now, this is an experimental study that actually we are sure that this can be translated into clinical practice, and it is likely that in future we can treat patients of chronic pancreatitis, reverse fibrosis, maybe converting them into normal pancreas. The other question that is constantly asked is, can we regenerate food pipe? We have a lot of these children which are born with esophageal atresia. Initially, we do major surgical procedures or end up with feeding jejunostomies. Movies show that, yes, it can be regenerated. For the first ever time, we started this experimental work in our own hospital. We took this rabbit, dissected out the esophagus actually, and then subsequently took out a centimeter of this esophagus, and then put a stent which is covered by a scaffold which has got pluripotent stem cells. Now, surprisingly, we are able to show that this 1 centimeter of esophagus which we removed has grown in the animal. This stent which is covered with the scaffold, pluripotent stem cells, and it has shown that we can grow a centimeter of esophagus in animal models. This is going to be a big revolution in surgical practice. Like the grafts that we use in vascular surgery, it is likely that we can use segments of this which are cultured, made in the lab, which can be used for surgical reconstruction. A lot of epidemiological work is done from our IBD team to show the IBD incidence in different parts of our own country, which so far was not available. And our own people are working in different types of microbiomes. And as in today, we know that every single disease seems to be related to gut microbiome. It is not the heart that is the face of the, I mean, everybody, you look at the thing, the face, you tell them that the heart's condition reflected on the face, but it is the gut's condition that is reflected on the face. A lot of work which is being done, and it has been shown that manipulation of gut microbiota can lead to curing many of the diseases, from neurological diseases to cardiovascular diseases. And also we have our own people who have worked on different types of diets actually, and they've shown that Mediterranean diet is the best, and we have found an InMed diet which is similar to this, and this can set the gut microbiota to normal, helping in treating a lot of these patients. And this is an InMed diet that was designed in our own hospital. If you want, actually, I can share the recipes with Dr. Sangram. It can be circulated. Likewise, we started having a huge biobank in our own department. Every single tissue that comes out of the theaters is stored here. And we have several Nobel Prize laureates who have come here, including Leroy Hood. And we know that in future, any of the new drugs that are produced, we usually test them on humans. But this is becoming very, very difficult. And now these new drugs can be tested on cell lines, and we have a huge repository of different types of malignancy in our hospital. And likely that actually very soon we'll be testing some of these newer drugs on these cell lines to see whether they're effective or not. And we also have a new team led by Santanu, which is doing a lot of work. And we recently started the Center of Artificial Intelligence and Innovation in AIG Hospital, because we know that AI is getting into clinical practice every day. Not only in clinical practice, it is our day-to-day use.
I will
Now,
assist
for the
patients
first ever
and
time,
care
we
professionals
designed
replace them. My goal is to enhance patient experience with human.
The first ever time we made this medical information robotic system. A lot of people thought we are creating a alternative to humans, but when we ask this Mira, we call that, it says that it is not a replacement for clinicians, but it is going to have.
And in the future, with appropriate training, my role may increase for evidence-based circumstantial requirements. I look forward to learning from the clinicians' experiences to continuously enhance my skills in the field of gastroenterology and other specialties.
So this Mira is there on all the digital screens in our outpatient right now. It is helping us in counseling patients, she is able to answer all basic questions. She is getting updated every day through PubMed, Gemini, and Perplexity. And sometimes we feel that she has better knowledge than the clinicians. Most of as in today, she is not prescribing drugs, but she is able to answer a lot of these queries which the patients have regarding the diet, medications, and all these things. Likewise, actually, we also started our own department. Whenever patient you refer for surgery, Sangram used to complain that the patient is coming in the morning and the patient is taking 2 days for the preoperative evaluation before he goes for surgery. We checked that we've seen that the patient and the attendants are taking almost about 8,000 steps in the hospital, right from blood sample to X-ray to 2D echo to cardiology consultation to anesthetic checkup. So now we designed a pre-surgery launch where we integrated this entire thing into one place. We have a problem, we found a solution through AI, and now the entire process of pre-anesthetic evaluation is done within 2 hours and the patient is sent back. Likewise, we have this in the endoscopy department and the OR, we have this tracker wherein every single patient is being monitored, and we know how many patients registered, how many patients completed the endoscopy procedures, how many in progress, how many in waiting, and we also know how much time they're taking from the time they come to the endoscopy department till the completion. So we also know which endoscopy rooms are vacant so that we can hasten and where it is getting slowed down. So we are able to track and then optimize the endoscopy suites right now. So it's billing and operational data from the procedures is becoming easier to collect. So it is improving the overall time for the patients from the time they come to the hospital to go out. Again, you all know about fatty liver now. Actually, as in today, FibroScan is the test of choice to quantify the amount of fat in the fibrosis. And for the first ever time, we have designed our own algorithm right now, which will cost only a few rupees. So we can avoid a FibroScan, and it is showing that it can do it with almost 95% accuracy. And also we have this technology called Prism right now, wherein because for all this to happen, this entire data has to be entered into the medical records, and doctors were finding it difficult to type it out. So now we have devised a thing wherein as you're talking to the data automatically gets recorded. This is Dr. Reddy talking to the patient So whatever language you talk, the entire thing gets translated. And even if you flirt with the patient during the thing, that is filtered. Only relevant information is taken, and at the end of the thing is segmented. See this, how it gives It gives a beautiful summary of the whole thing in whatever language you talk. And the biggest thing is what is happening now. We get patients from across the country, different languages. Now this is able to dynamically convert whatever language is spoken into English so that we don't have to have a translator right now. And also this is a sepsis prediction model that is installed in AIG Hospital. Every single patient data is now entered right now. And we have umpteen number of parameters that we are monitoring, and these are able to predict which of these patients are going to septic shock. And surprisingly, we are able to monitor these things so very closely that the number of patients who are going to septic talks most of them are being salvaged right now. And the number of code blues that are happening in the hospital have dramatically reduced. Actually, any of you coming to the thing will be glad to showcase this that is there in AIG hospital. Likewise, surgeons and endoscopists doing procedures right now, they are being tracked to see that they don't have any physical trauma, because this is one of the causes of burnout because of development of osteoarthritis or limitation of joint because of prolonged use of endoscopic or laparoscopic instrumentation. We are able to tell them which are the movements can be avoided so that they don't have this physical trauma. AI in IBD diseases, actually a lot of work is being done from diagnosis to treatment to follow. And here is one of the examples actually. Some of your patients would have undergone total proctocolectomy with an ileostomy for ulcerative colitis, or some with Crohn's disease. Now here what we divide, because these patients have to have a stoma bag and they have to keep emptying the bag continuously. For the first ever time, we started doing this continent stoma here, in the sense like it is like a cap on the bottle. So we put this device so that he or she can empty the bowel at his or her convenience. You can see this. This is the cap that is fitted onto the thing. Now there is no artificial intelligence. So now what we did was we put sensors into this device here. Now this device is connected to the patient mobile and it tells us the pressure, the temperature, the pH level, the oxygenation levels, and as the number of sensors get incorporated, more and more sensors get incorporated, it works like a smart toilet, including fecal protectin and other markers can be monitored. So it becomes very, very easy to monitor and follow up these patients even from a remote city. Like polyps, again, colonoscopy, we detect this polyp. This is an AIG program which is enhancing the polyp color so that learners cannot miss this. You can see this is the white light endoscopy. This is the enhanced polyp. So as we are doing, we don't miss these polyps. And when we do this, actually, we also started doing this POEM procedures, which a lot of POEM with Achilles cardia. Now, some of the youngsters are doing, we could have some complications. Now, this is AI integrated POEM procedure, wherein as you're doing the procedure, it will tell you whether it's the subcorrect plane. And as you're encroaching some major vessels, actually, it will highlight the vessel and it will tell us that these vessels need to be coagulated. And unless and until you coagulate, it does not allow you to proceed. So you can see on the left, it shows us submucosal injection, which plane are you in correctly, whether the sling fibers are identified, whether they're cut. You understand, as you go through the procedure, it continuously monitors you during this entire procedure. Likewise, actually, this SPICE scope that is used, actually, a lot of you know about this, actually, SPICE cholangioscope, which is used for biliary strictures, a lot of indeterminate strictures. Biopsies from this yield accuracy of only about 60%, basically because of the size of biopsies that we get. Now, when we incorporate artificial intelligence into this, the accuracy becomes almost 90%. So AI is making a big change in the way in which we treat in biliary strictures. Again, this is another campaign that is started from AIG Hospital. This is for pregnant ladies. As a part of CSR activity, we started doing this. It is called Janani Mitra. Now, as in today, we are able to track pregnant ladies across Andhra Pradesh and Telangana. As in today, we have about 6,800 pregnant ladies who are being monitored about their vitals, about their food, what they're taking, about any emergencies that can happen. So these are all linked to a war room so that any emergency that occurs can be tackled immediately. Surprisingly, the initial data shows that actually the maternal mortality and the infant mortality has dramatically reduced. And we have some of these abortions have also been cut down. And the government of India is taking up this project in a big way. And we hope that it gets the national recognition very soon. Now, who is funding this research? Actually, there are various agencies. Initially, people who never used to believe in God used to fund this because these are the people who believed in science. But at AIG Hospital, we have Asian Healthcare Foundation, MedTech Board, and Center for Artificial Intelligence. These are the things that are finding, and we have more than 600 publications, chapters, and several patents as in today. Now, this entire translational research requires clinicians and research working in tandem. As in today, clinicians work in a different way, research goes in a different way. What we want is both of them were to work in a tandem so that we have a new species called clinician scientists. And for this to happen, the clinician should have some time to do research. So he has to have some time between clinicals and so that whatever small problem that he has can be used to think what can be done, and this can be translated. So it is something like you have to share your screen space between clinics and research. Everybody wants to share their screen space. Likewise, we should also find some space for research so that we can translate this into clinical practice. The other thing that has come is the omics study. Actually, we have a lot of omics that have come, genomics, epigenomics, transcriptomics. All these are changing the entire way in which we are practicing medicine. We have multi-omics which combine all these things. There is huge data that is coming from all these omics, which is heterogeneous, and analysis is time consuming, and AI is helping us in decoding and is able to overcome a lot of challenges that we have in current day clinical practice. And ultimately, it is able to analyze faster, leading to personalized. So in addition to the genomic, the multi-omics that we talk about, there is an emergence of surgeomics, that is the surgical factors, like my factor, surgeon who's doing, clinicomics, the clinician's factors, pathomics, the pathologist factor. All these are new specialties that are emerging, that are integrating into this omics specialty to take this into a next level. And you're talking about pathomics, clinicomics, surgeomics, multi-omics combining to what is called as personalized medicine, with a collaborative effect of clinicians, data scientists, and ethicists. So, like we keep saying, actually, most of you are personal physicians to big people. None of us have personal scientists, and the future is all about the personalized clinician scientists. And the doctor could be out, they will have personalized clinician scientists who could monitor the patient. We started this department of personalized medicine and precision medicine at our own hospital, which includes even pharmacogenomics. As in today, I think you must have all heard about Dr. Reddy talking about pharmacogenomics. As in today, there are some patients who have multiple drugs actually. It is not necessary that these multiple drugs are required, and the dosing could also be different. Single one-time pharmacogenomic study of this patient, which is done on a blood sample, which is costing about 5,000 to 6,000 rupees, will tell us what is the optimal dosing of this drug, and this can change to phenomenal change in the way in which we practice. Our cardiologists right now have started standardizing the amount of blood thinners based on this. Actually, they feel that it is not the same dose that is required for all the patients. So keeping in view all this research, someday, I think initially I thought this will be too long a day, but recently Sundar Pichai has come out with a quantum below chip, which shows that actually what can be done in the next 40 years can be done in the next 5 years. So I hope something like this becomes true. As in today, we have the smart chairs which pick up all the data. Patient lies down on the table, actually picks up the data, diagnosis, and file. For all this, I thought I'll have to wait and become something like this 2 decades younger. I created an AI image of myself. But I told you, Sundar Pichai introduced Willow, and I don't have to become like this to see all these changes. So finally, to conclude, research has taken a backseat in current day medical curriculum and practice. This is basically because of variable factors. The clinician scientist concept is waning and would soon be extinct if we don't act appropriately. Clinicians' interest in research is essential for better understanding of disease. Research in any form would enable best treatment policies. Clinician-scientist interactions help in innovative solutions to diseases and improve translational outcomes. And we're looking forward to a research of clinicians and scientists. And I thank the entire faculty and staff at AAG Hospital for the unconditional support, and the Asian Healthcare Foundation for funding majority of these projects that we are doing at AAG Hospital. And we are looking forward to this day wherein we have an AIGN on the way to the Stockholm to receive the Nobel Prize. Thank you so much once again for the hearing and the honor of this screen this evening.
So what can I say?
Dr. Murali Mohan sir, 1 minute. Dr. Jyotirmay Paul has joined. He wants to have his remarks.
Sure.
Dr. Jyoti, can you go ahead?
Thank you, Dr. Sangram Biradar, Dr. P.S. Shankar, Dr. Ravi Kirti, Dr. Suresh. All have taken initiative to conduct this week as a research week. One of the aims and objective of API is to promotion of the research, particularly to increase the awareness of the research among the students and physicians. Because like many other fields in medical research, India is not much ahead. So it is a duty of our organization to increase the interest and awareness of the research of the younger generation, so that in future India can be at par with of medical research with Western countries. And also India has an immense potential to invent new drugs for the diseases. So that is why the methodology of the clinical trials is very much needed. So I hope the way API will promote the awareness of the research. At the same time, government and non-government agencies will come forward to promote the invest in the medical research field, which is not sufficient till now. Our research wing under leadership of Dr. Muruganathan is going very well. He is taking a lot of interest to promote the research among the physicians and taken a lot of initiative, lot of project, which may be completed over few years. And I hope the way Karnataka API is taking the initiative should be example to other state branch of API. Thank you. Over to Dr.
Yeah, thank you, Dr. Jyoti, for sparing your valuable time. Over to Dr. Murali Mohan.
Dr. Rao, what can I say? That's one of the most inspiring talks I have ever heard. And I've heard talks from around the world. It's great to see the kind of world-class work y'all are doing. And I think you've given us a glimpse of the future. So hats off to you and your team, Dr. Nagesha Reddy, the whole of AIG. I mean, this is absolutely amazing work. And I hope people who are listening are somewhat inspired to take this just a little further. So we have, three panelists here, but what I would suggest is I will ask each panelist the question. Please feel free to respond, but other panelists feel free to come in and add your points to this. And of course, we have a wealth of knowledge among the listeners here, and we will get their inputs on the chat box also. I'll try and keep track of the chat box. Dr. Rao, I will invite you to stay and contribute to the topic. I hope you're not too busy and need to go away. So my first question, and I will start with Dr. Kusal Das. In your opinion, why should a busy practicing physician engage in or at least stay current with medical research? Why, as practitioners, do we need medical research?
Thank you very much. Thank you very much, Professor. First of all, I like to really give thanks to Dr. Rao for world-class lecture he has given. I have already heard his lecture earlier also. Always it is interesting and very much thought-provoking. His lecture actually first given the idea about the basic sciences, how it connect to the clinical medicine together. And one interesting part of it that he has actually combined not only the surgery but also the medicine together and make it a proper way for innovative aspects to discover and invention. So this is actually the most important part of this topic title today, the research and innovation. So his lecture covered all. Now, I think that his lecture must inspire all the physicians why they should require to go for the research. India is one of the country where 140 million population and so much of diseases concern it is having that many of the diseases are unknown to the rest of the world. So these diseases are actually not been properly reported, how it is treated, how it is controlled, how it is regulated, what are the data, even the simple data itself are not been known to the Western countries. And that has been very much clear when I was in the UK as a professor there, and I found that they are very much surprised to know that how that I myself has suffered from the malaria twice. So they could not believe it is that exactly it happens to a person who is a who is a physician's community and they themselves are suffering. It means the knowledge of India which generated are not been shared. Now, whose responsibility? Responsibility is the doctors. So there should be informations and all the things, whatever they found, must share. We are India, we are very much lack of the collaboration with each other. If we get something, we keep and store only in our database, we never share. If we share, we want to share it to the journals. But the question is that many journals are not accessible to all the readers, and all the physicians are not reading all the articles. So they are required the platform like API to make the understanding and all, and more sharing platform of each of the new ideas, new thoughts, and new way to treat, which reflected by many of the case reports, specifically by the physicians and surgeons to the academic domain. This is required, because until we know that what are the varieties and what are the new things are actually coming up, how it is changing, may not be possible to go for the genome sequences or any other genetic parts at all, or even the artificial intelligence use and knowledge is still not been that much popular, although it is very important and it is actually challenging, and it is going to be a competitor to replace the manual many of the performances. There's a reason it said that probably the physicians required more than surgeons for understanding AI and adopt themselves immediately. For that, the research is very important. So own understanding, knowledge sharing, gaining the knowledge, distributing the knowledge pattern, and try to find out how it can be explored or how it can be applied, both the way. And that's the reason research is very much important for any physicians of our country. That's what I want to say.
Thank you,
Thank you.
Dr. Das. Actually, I'll just add to the thing. Actually, I keep telling this. Actually, as in today, 1% of the entire medical population is publishing. They're doing some research and publishing. 9% of the clinicians are propagating this research, and 90% of us are following blindly without questioning.
Exactly.
What we want is research, and we want AI to come in a big way so that we 90% could get into that 1% of the thing. Then only I think our voice will be heard.
Exactly. We should be more aware of that, and it's a challenge. AI is a challenge for the medical community itself. Everything from investigation to diagnostic to therapeutics, everything, except probably some of the surgical methods may not be may require the skills, but rest of them are challenging. So it is a high time to adopt ourselves with these current changes, and changing means the research. Research is the change of the medical dynamics.
So it is challenging the surgeons also. Actually, I don't know whether you know the thing. The first ever cholecystectomy was already done without the help of a surgeon. It is that the system is trained on so many gallbladders that it is able to do without causing a bile duct injury.
Yes, that's the reason. But still, there is some scope in the surgical part to. Scope means only the time delay. It will cover up. But the time is going very fast for the physicians at the moment. This is I wanted to.
Yeah.
So one of the areas that AI perhaps was thought not to challenge physicians was in the area of empathy. There was a recent paper showing that AI did even better on empathy than doctors. Of course, these were responses, not a face-to-face confrontation. So I think the important thing is AI is going to take over our lives, and we must either learn to use it, become its masters and use it to our benefit, or be its slaves. And I think that's an important challenge that we are going to face in future.
Actually, just to answer to your question, actually, this regarding empathy, actually, as you very rightly said, AI is shown that it can empathize. Actually, there is a recent study which shows that 40% of the clinicians are getting Botoxed. Once you get Botoxed, you cannot frown, you cannot smile. So the empathy factor is gone.
Yes.
You understand? So beautiful data to show that 40% of the clinicians are Botoxed. So, I mean, the machine can sympathize better than the humans.
Well said, sir. So I'm going to go to Dr. Ravindran for the next question. Dr. Ravindran, your views on why research is useful to make us better clinicians, because that's what, as clinicians, we are interested in day-to-day practice. Is research going to make us better physicians or not?
Thank you. And thank Dr. Sangram sir for putting this event together. And before I answer your question, Dr. Murli, I would beg to differ with views shared about the AI. I think it is being overhyped, and there are human qualities, including empathy, where there is absolutely no substitute. If you look at the research related to AI, and which Dr. Rao himself has shown, it has got great success where precision is required. But practicing clinical medicine is not about precision. It is about intuition. It is about the assessment which only your trained mind and the overall inputs you had over the years will give. So I because I mainly come to this program as somebody who has got a bit of editorial experience with my editorship with several journals. So what research we see related to AI, we just discussed the digital twins. One article recently, I was at the editorial board meeting just now of Rheumatology Oxford. So I think we just have to, I think we are actually overhyping. We are saying that AI will take over. We are saying that we are actually empowering AI. What AI does is actually very limited. Okay, and if you look at the domains which have been covered, they themselves are very limited. So they are about precision surgery. They are about precision diagnostics also in very specific areas. It has not sort of, percolated even after 15 years. It has not percolated to what constitutes the root of practicing clinical medicine. So with that coming specifically to your question, so why it is, so does doing research make you a better clinician? That was the question, Dr.
That's
Murli,
right. Yes.
Okay. So the short answer would be yes. Of course, it will. So one of the key things I see research as a tool for you to able to appraise a published research in a proper way. So having done research is a way to know what actually research entails, and it actually enables you to learn the nitty-gritty of research so that you can assimilate for your own clinical practice what is good for you and what is not good. And that is basically what is clinical evidence-based practice constitute. So if you look at the postgraduate research, so you know that, like all of you, the postgraduate research is actually phenomenal in India. The idea of postgraduate research, I always believe, is to teach the postgraduates how to do research. It may or may not be linked to the publications at all, but that is not the goal. So we want to train the postgraduates how to do the research, they understand the sort of the ethics involved in conducting research, and learn the process so that you go on to develop research leadership roles in future, and whatever you tend to sort of do and publish, that confirms to that. It also helps in you becoming a better clinician, because the inputs you have in a formal environment of research is also very important to guide your sort of intuition. And sometimes when we do things, when we do research, we understand sort of, how things are not that sort of black and white as we sort of, used to think about certain clinical scenarios. So there is always a gray area. So it is actually the ability to assess this gray area and the uncertainty in a specific clinical scenario, which makes you a better clinician. And this is a daily, day-to-day tussle which we have in our clinical practice. So I'm particularly focusing on the postgraduate research because, I mean, I really believe that probably that is one area where we are actually failing, and we are hoping that people who become consultant and sort of tend to develop a busy clinical career would do a substantial research. So that is not going to be happening. So it is the sort of, the very root of the problem. I feel that there is a dissociation between our expectations in terms of people who do research and who do teaching, generally worldwide. But here what we want is we want the person to do absolutely everything, which is not possible. Thank you.
Absolutely. Thank you, sir. I just would like to point out that, we are not saying that AI has already conquered the area of empathy. We're also not saying that AI has reached where it is. But I think the growth in AI, the speed which it is learning from us, is not being replicated with the speed with which we are learning from AI. And I think that's the big difference.
That is right, Dr. Murli. It is actually 100 physicians putting together their data. It is instead of one physician deciding, the AI picks up so much of data that it is able to pull in so much of data. That is the biggest advantage of this, actually. Again, as you rightly said, it takes time. Like every science is very slow. It takes time. But the way AI is going, actually, I mean, within few years, actually, we are seeing a lot of transformation, actually. So, I mean, you understand, as in today, I don't have to do a laparoscopic Whipples to show you that I can do a Whipple procedure. I can go to the software and create a video and show it to you. You understand?
Dr. Rao, what I was saying that, you need an AI
Yes.
deliverer.
Yes, absolutely
to
right.
practice the 100% AI based medicine.
That's what you feed in.
Now, so
data, you get
so
good data.
I mean, so I have all the AI. So you can say, so for we have started to say that this AI generated manuscripts. Now we need an AI editor.
Yeah.
And we need the AI reader.
Yeah, right.
And we need the AI care providers to make a sense out of it.
Yeah, right.
So,
Absolutely right.
so the thing is that we have a lot of technological inputs. Okay, so like I mean, so it's like so an automobile which can be driven without sort of unmanned. So till we are at the stage of practicing medicine unmanned or no physician involved, I think we are safe actually. So that is the critical human interface I say. So nothing against the technology. Technology has grown, but I still feel that there are only very specific areas where you need the AI.
You're very right, actually.
Absolutely.
And the honor, sir, of maintaining the sanctity of clinical medicine rests with us actually.
Absolutely right. You're absolutely right.
Absolutely.
Thank you, sir.
So, Dr. Sangram, is Dr. Pragnya Yadav here? Because I don't see her.
No, sir. She is still in another meeting. She will be joining at any time. I will let you know once she joins.
Sure. In the meantime, can I request Dr. Srikanth Hegde? I think he's one of the listeners. He's also our editor of the Journal of Internal Medicine Karnataka. Dr. Srikanth is also a very, very good clinician, a quizzer, and very much involved in research. I'm going to ask him, Dr. Srikanth, what are the most significant barriers you've personally faced or observed that prevents clinicians from getting involved in research? Dr. Srikanth, I hope you're still here.
So good evening.
Good evening.
Yeah, good evening. For a clinician to enter into the main problem would be awareness about research methodologies for a practicing clinician. Probably these are not the things which generally are not taught in the postgraduate programs. Mainly as they would have done mainly a theory, thesis. But to put the same thing into clinical practice, we have as a clinicians, we have a lot of data from practicing from the patients, but they are not organized in the form of the data which is required for a scientific publication or a research. We faced this problem when recently we had together from a small town in Shimoga, we had data about more than 1,000 patients of ABPM, but we couldn't put it into a paper worth publishing in a good journal because when you do the study, the protocol has to be decided up front. But when you have data and to think that how to put that data into a paper, you find a lot of difficulties. Like the data is not, you don't have a structured question, you don't have a clearly defined objective. So having data cannot translate it into a paper. So to have a paper, you should have objectives set beforehand and to study the objectives and to collect the data based on the objectives. That is where most of our clinical practice fails to translate into publication. That's my this thing.
Excellent. Thank you, sir. So Dr. Suresh Sagarad, our immediate past chairman, has posted an interesting question. He says, how do you make postgraduate research work quality control? Because very often we know that the quality is not good. There's a lot of fudging of data, let's be honest about it. Things are made up. And so how do we make this better controlled? Because this is the starting point. People who start badly tend to continue badly. So can I request Dr. Kusaldas to tell us, how do you control the quality of postgraduate research work? Very often the thesis.
Yes, sir. This is a very, very important question, that how the quality of the postgraduate students of our medical schools are actually being monitored, regulated, and guided. This is really question. But currently, the postgraduate students are going under this training. Almost all the departments, all the medical colleges, they routinely does it, and it is in the part of the curriculum by NMC. So there is no problem at the moment because students are learning that how to keep maintain the ethics, and they are appearing compulsory appearing for BCBR examination, and they have to clear it before the final PG exam. So all these things actually making the students of current generation, not in our generation, we are not being trained in that way, but now current generations are properly being trained in this aspect. But this is really challenging, that how they will maintain the ethics and being an authorship part, and how to write an article in a proper decent way, who should be the considered as an authors. And one point here I like to just ask Dr. Rao, that as per Dr. Rao has mentioned that clinical scientist as the word. So is it possible to our country to make the research nurse the policy of the research nurse, which is adopted in the Western country, specifically UK, the research nurse are available? Is it possible in India, or any thought of it? I have no idea, because as per the medical school concern, such nursing staffs are not available who are actually being guided. The students, specifically PG students, when they're collecting the data on the field or in the by the side of the patient, when mentor may not be available that time. So this is one part we are lacking. I think this is one of the issue API can ask that to include the research nurse position. If Dr. Rao thinks that such things also being required, or API thinks like this is possible. So this is my question, my point of discussion in this regard.
Very good question. Actually, see, research assistants are available right now. Actually, in AIG hospital, we have almost about 42 research assistants, which are attached to individual physicians.
I'm talking about the research nurse.
Yeah, actually, this research nurses, as of today, we don't have, but we have research
because of the clinical purpose.
Because the nurses are not that very well trained, actually. So, but we have these research assistants who are able to do, and they're doing most of the work right now. Actually, they're now it's a separate specialty by itself, actually, and they're getting employed everywhere. Actually, research assistants actually there, but nursing staff, as in today, I don't think that. Actually, we have Dr. Vinod actually.
Yes.
Thank you, sir. Not. I think that question I agree. Here, sir, basically the clinical research officers or assistants, they do the work which research nurses do in United Kingdom.
Yeah.
Regarding the postgraduate research quality, I think we have unrealistic expectations from the postgraduate training in India. So we want them to be, very busy learning the clinical side of their specialty. And at the same time, we want them to do substantial research. I think that is actually the challenge. I think as Dr. Vitul Gupta said in the chat, that actually it very much depends on the supervisors, the leadership role in terms of how the postgraduate trainee under him or her would do the research. Because thinking of a good research question and thinking through the methodological aspects and the ethical aspects is important right from the very beginning. One area I feel that where things can be improved is, as I think in the talk also it was said that actually collaborative research is the way forward now, because I mean, thinking of me at my own center, my special interest is reproductive rheumatology. But reproductive rheumatology in itself, you can see it's a sort of very rare sort of, type of scenarios we are dealing in a specialty which already deals with very rare type of diseases. So the way forward, of course, for me also would be to do collaborative research. Now, this is, we are not teaching to the postgraduate. My contention would be that why is this expectation that, only one postgraduate to one supervisor? So we can have sort of 5-7 postgraduates actually collaborating a study, and they learn how the collaboration works. And in terms of learning the leadership and the collaborative side of things, to how to keep the things moving forward, I think that could be an important skill to learn. And then, of course, the link to that is this pressure. I mean, I would not say that at the postgraduate level that pressure is too much, that is publish or perish, but still sort of we want them to finish that in less than actually 12 months. That is the reality of it. So I don't think unless, so I was just going through the last actually 6 Epicons postgraduate sort of, abstracts presented because of some other sort of idea I had in mind. And actually then I thought about in 2020, when I presented my postgraduate thesis as an abstract at Epicon Jaipur. Actually, we see the same type of abstracts even now. Hardly any innovation. And that is a reflection of the time pressure and sort of, this unrealistic expectation. So naturally, the quality suffers. So I think collaborative work and just sort of, somehow, even I don't upfront have any ideas that how to sort of, because of course, it is learning the essential skill of research conduct is an integral part of postgraduate training. And this is where sort of, that thing we are not being able to carve out in terms of our expectation to the postgraduate trainees and their subsequent sort of, behavior in terms of the real world scenarios in terms of research. Thank you.
So that's an excellent point about collaborative research and how different postgraduates from different departments can work together on a single project and each publish their own, aspect of it as their thesis. So that's an excellent idea. I wish really the National Medical Council takes this up and runs with that idea, because that in reality is what research is going to be later, not one person publishing on one thing. Excellent point, Dr. Ravindran. But the problem also is that we are clinicians and we deal with day-to-day clinical problems. So I'm going to ask you specifically, and I would like Dr. Rao to come across with his ideas on this also. How do you identify a good research question from the clinical problems we encounter every day? Because every day we have clinical problems. And as you said, we just go back into the literature from the West if we are inclined to answer the question, or we just muddle on and do things. So what is the best way to say, this is a research question that I should be exploring? We'll start with Dr. Ravindran and then go to Dr. Rao.
Dr. Ravindran, your voice is a little low. Kindly.
Is it? Yeah, I will increase. Hang on. Yeah. Is it better, sir?
Yes.
I will just, yeah. I think this is a great question. So there are multiple ways of coming up with a good research question. And one of the key things is that you should be, a widely read person in terms of research would be able to assess better what is the requirements as far as his or her own environment is concerned. I would link the research question to the feasibility of doing that particular research. So both have to be thought through right at the beginning. We may have some great ideas, but it is just not possible to do them in whatever the setting. So, like, for example, I may have some great ideas. So, one way is to give you an example of reproductive rheumatology. We thought that, there are a lot of observations about lupus and its effect on pregnancies, and it's a globally you have a lot of data available, but we do not have that much of information for rheumatoid arthritis related pregnancy outcomes. So what we thought, yeah, okay, this is very good, and this is not being sort of done in India per se. Then we thought about, what is the feasibility of it? So then came the question of how to make it a collaborative approach. So in terms of doing this particular research, we formed a prospective registry looking at the pregnancy or the obstetric outcomes in rheumatoid arthritis. So we had 17 centers, and the work is ongoing. And each 17 center, so we have to go for the independent ethical approval, which is again a major challenge. So I think, from the practicality side of it, here in India, unless you are in that type of academic setup where virtually everything is possible, as a clinician, you have to think what is the feasibility of that particular research question. Thank you.
Absolutely. Dr. Rao?
Yeah, very right, Dr. Ravindran, what you said actually. But actually, what I would suggest actually would be the postgraduates ask simple questions for everything they do in clinical practice. See, I am putting a Ryle's tube for a patient undergoing gastrectomy. The question is, should the Ryle's tube be put or not? I am preparing the bowel for a patient undergoing colonic resection. Is bowel preparation required or not? These are simple questions that can be answered actually, and there is a lot of data which is coming up on these simple questions. Like yesterday, last week, I was in the theater. I have one IIT graduate actually who is in the theater, biomedical engineer who's in the theater. She was surprised to see that I'm using still the scalpel to make an incision. She says, "You're outdated, Dr. Rao. You should be using something new to make an incision, not this age-old scalpel." So you understand what I'm saying? For every single thing that you do today, you should ask a question, is it the right thing or something else can be done for this? That itself is a big research area. I mean, the postgraduates actually, I think they can do this, does not require much funding, anything of that sort actually. So this itself is a type of research. I mean, and as you go on to the thing, actually, as Dr. Ravindran said, actually, we get more and more inputs, more and more data, more and more equipment to complex, more solved. But start with simple problems. I think we should be able to get good answers to this.
I think one of the major issues really is we need to have inquiring minds.
Absolutely right.
Yeah.
You struck on the nail actually. You struck on the nail actually. You're absolutely right.
So, when we were talking about barriers, Dr. Suresh Sagarad has posted a comment, time, funding, awareness are critical barriers. Dr. Sagarad, I'm going to request you to expand on that answer. Time, funding, and awareness. What are these barriers and how do we overcome them?
Yeah, Dr. Murali, thank you for that. This one taking up. See, because most of in India actually practitioners are very busy. We are not like USA or UK where you have a very limited number of patients you have to see, but especially in government sector we are seeing hundreds of patients. The converting that into data, we lack a lot of infrastructure. We don't have funding for specifically for research activities. So that's where the problem comes.
You also said that, it's the awareness is a critical barrier. So
yeah, research methodology is also not taught. So that is also a critical area where, and see even the medical colleges are not, well equipped for research. To get one ethical committee clearance, it takes months together. They won't, get repeated meetings or, that kind of situation is there. You apply, you wait for 3-4 months to get a clearance. So there are these kind of barriers are still there.
So we are running out of time. Dr. Sangram, how much more time do we have?
Can I just add one point?
Sir,
Yes.
please.
Certainly, sir. Please go ahead. And after that, I'll request Dr. Sangram to tell us how much time
just
we
one
have.
point I want to add in this interesting topic. I think that India, first, one thing that lacking in the medical schools, which is not in the other higher education sector, that is the proper mentoring. Mentoring for research, mentoring for service we made. Our whole objective to mentor it for tomorrow's doctor, to make them to serve, how to serve. But how to do research, this mentoring is quite different than how to serve. This is the first difference we are there. So we do not have the infrastructure is not the first question. The mentor itself, if he is properly been trained and properly gone under the same phase and phenomena, so he will show the student the light, and automatically the vision will come and the thought process will evacuate. That is the lacking here in India, specifically for postgraduate students. I personally find myself as well.
Absolutely. In fact, that was going to be my next question. What is the role of mentorship in a physician's research journey? And what is the best way to find and approach a mentor, a potential mentor? Dr. Das, you can go ahead since you raised the point of the mentor.
Okay, yeah, that is the thing. I can give an example. When I went to UCL London for my postdoctoral fellowship, my supervisor, he's no more now, he was a surgeon, he was a urologist, and I'm a physiologist, totally different from the field itself. So he's a surgeon, FRCS, and he's totally busy in the surgery and all, and enjoying the life in a different way. But the project from MRC, he got it, that is connected with one part is a physiologist. Now, very interestingly, I first thought the surgeon, how he will actually make me to give the idea to do further work in this line. But to my surprise, I found that he has a clear vision of the project, clear idea and thought of the project, clear understanding of the surroundings and infrastructure availability. And as for the collaboration, what is not availability there is available in the Imperial College. So one can share the laboratory in the Imperial College also. That's the way. Whole thing, he made a plan, though he's a surgeon, not connected to the physiology, but this is the mentoring, which I personally find. This mentoring is lacking in India. So this is the part where we require the student who is actually completely unknown to the journey of the research, and to show him the path or ask him to read what he should read, what he should practice. That is very important. And this is required the illumination, totally, I think that enlightenment by the mentorship. It is a great role, specifically for the postgraduate, medical schools. This mentorship is a very important, but it is taken very lightly here. Because mentorship, as if the medical college distributed the guides among the other professors, associate professor, assistant professor, and they take the student and the guide, not exactly the involved either mentally or in the psychologically or in the subject academic domain towards the same line and wavelength with the whole environment. So this is the reason we goes lacking, and our doctors, we are not ultimately going to make them as a great researcher for tomorrow. We prepare great consultant, great physician, great surgeon for tomorrow, and whole world accept it, but we could not produce the same in case of the research. That's the gap.
And in fact, I'm going to read out a couple of things that Professor Dr. Vital Gupta has written. He says research questions arise very frequently related to epidemiology, prevention or clinical issues like evaluation of inhaler techniques, insulin injections, prescription patterns, various diseases, etc. And I'm going to come back to that point that he made. And also, he says that an important barrier for clinicians is the recognition of research and any incentives for private doctors. So going back to the previous point that he made, so some of this goes across into the area of audit as opposed to research. So I'm going to ask Dr. Shrikant Hegde. Dr. Shrikant, audit, is it important, and is it different from research, and can we publish audit in your journal?
Sir, I didn't get your question. Which audits? Prescription audit or?
Any kind of audit, clinical audit, is it important to do? Is that something that is a starting point for research? And how does it differ from clinical research? And specifically in your journal, can audits also be published? For example, Dr. Gupta spoke about research questions related to insulin injections or evaluation of inhaler techniques. That really would come more in the region of audits rather than clinical research. Though you can publish research on the same.
We can publish, sir. We can publish. There are even, in fact, we have published some recently similar things like assessing the availability of mosquito nets and other things. How medicated mosquito nets. There are few things we have published on foot care. Regarding foot care.
Sorry, I think we're losing you.
Clinic practice of diabetic foot rural community like that.
Fine, sir. So, Dr.
some questions, some type of papers like.
Yeah. We will have a concluding remarks from all the faculty.
So I'm going to request all our, starting with Dr. Kusaldas, one concluding remark because we're running out of time.
Thank you very much. Thank you, Dr. Sangram Biradar, and thank you, Professor Murali, for giving me opportunity to speak here with you. And my remark is that research is still not being taken seriously by the medical council or by the community or by ourselves. Whatever we say, we just make the research as just a part of the whole curriculum of academic curriculum purpose, not purpose of the fulfillment and development and design. So I think that we require now to be more concerned to ourselves for existence and fighting and challenge with the AI and other research related development and growth. We have to update ourselves, and that's the reason we have to modify by ourselves by making the new thoughts, new idea, new things. We have to impart also to our postgraduate students and the future generation of specialists and doctors. This is my conclusion.
Thank you. Before we go to the other panelists, I'm going to request Dr. Chandrasekhar Puttappa. He is our chairman of the Medical Education Research Trust. Professor Chandrasekhar, can you tell us a little about the Medical Education Research Trust and how many applications you get for research grants? Sir, Dr. Puttappa Chandrasekhar, I don't know if he's on. If he's not, I will request Dr. Vinod Ravindran to give me his closing remark.
Thank you. I think this was a great session. What I would say to everyone, whether you are based in institution or in non-institutional setups, private practices, think research as something which is feasible. So I think that should be the initial thought. Then second is link your aspirations with the reality of it. Don't think of your research going to be changing the world, but think how it will change you and what is in it going to be for you. I would say that if you have a good, simple research question, as Dr. Rao said, okay, then that answer is actually true to you. It will teach you and it will empower you to take the right clinical decisions because now you have an evidence. And then linked to that would be the outcome. What outcome you are looking. I mean, it can be, I've been happy with some of my good work, I think, that I could present in some of, good national and international meetings, and I could not publish it, but I'm happy with it. So I think, in terms of the overall outcome also, you have to be realistic. So think of research as something very feasible, doable, and all the challenges are surmountable. And then think realistic, what is the outcome going to be for you? Thank you.
Absolutely. Well said, sir.
Dr. Vitul Gupta want to say one comment. Dr.
Yes,
Vitul.
Sir, you're muted. Can you unmute, Professor Vitul Gupta?
Vitul Gupta, unmute.
Thank you very much, because education and research is my passion, in fact. In private practice, it is real difficult to go in for expensive research, and somebody has commented on research assistants or nurses. That will be really helpful. And in practice, the statisticians are also lacking. So you have to pay. So that is the financial burden. And most of the research you will see, as one of the speaker has commented, that it is in medical colleges because they need it. For private practitioner, there is no incentive to go for research. So that is the biggest barrier. And that is why India is lacking the Indian data. Whatever you do is going to contribute to the research purposes. Like epidemiology, you go for prevalence of hypertension, diabetes, or complications in diabetes, prescription patterns. Until unless we don't know what is happening in India, how we can devise the guidelines or further perspectives. And scientific research is divided into the drugs, the epidemiology, the public health. So I think the attitude is really important, and associations should go in for apprising their members to indulge in research by giving them multi-centric options. That multi-centers are involved in that. So that is my take. Thank you for giving me the opportunity, sir.
Thank you, sir. Dr. Suresh Sagarad, one closing comment from you, because you're going to be driving a lot of this for the Karnataka API. I'd like you to give us your closing comments on research and clinical medicine. You're muted, sir.
Actually, you are the driving force now because you are the in charge of PRF API Karnataka, and definitely from central side we will be supporting you as well as from the state side. So I was raising one question, that is whether a dedicated post-graduation in clinical research is a possibility. Any panelists can comment on that in the long term?
Dedicated research?
Post-graduation research.
What exactly you asked, sir? Sir, can you repeat it again? Dedicated
Sir,
research?
PG course dedicated to clinical research.
Yeah, actually it is there, but clinical research, not exactly by the MD curriculum and like that way, but each of the postgraduate curriculum now, the dedicated research part is there, that has to be cleared, and that examination is mandatory for postgraduate appearing before the final exam. So this is there. But career to make it a research, that depends on the students and his mentor's ability, how it has been motivated and that. And that's the reason that depends upon the institutions. Like some of the premier institutions, they motivated students and dedicated them for clinical research, particularly for clinical trials and all, they're properly being trained. So such trainings are not available in the other 704 other ordinary medical colleges, not available. So there is a big gap. And there is no uniform policy, uniform stature is there. But the policy, there is a uniform, and that is the very minimal. So keeping ourselves in the minimal level of research, dedicated to the research is a quality dependent. That requires a lot of work to be done from the apex body, specifically for this regard. But it is possible. Why not? Because I can tell you that in the 2019 Nobel laureate Professor Greg Sabanger, I know him. So he got the Nobel Prize for his discovery of HIF1 alpha, specific target gene. But he's a pediatrician. So, but he was dedicated from the Johns Hopkins from the beginning only. After his MD, he was fully dedicated to research only. He was being trained and he was made it in that way. He actually did not do any practice in pediatrician as such. For entire life, he dedicated and he got Nobel Prize. That's the way that the training and is going on. We are still lot of, I think, lacking behind, I can say. We need time.
The problem is the funding, sir. You know, there you get
and the funding.
And now what is going to happen in the US, we have to see, because of the withdrawal of funding, it's going to really suffer.
Yes,
so I think that is going to be a big problem.
Yeah, PubMed was closed and there is no update in the PubMed. I think that today it has been solved yesterday. Now PubMed again are going to update now. We have lost many data. We are not been able to understand.
Absolutely.
Many articles have been published.
Yeah. So one of the pieces of research I'm actually most proud of just took a day, and it started with a simple question. When we use a spirometer, there are two kinds of mouthpieces, and we were wondering, one is tapering, one is a cylinder. Does the change in caliber make a difference? We did the study over the course of one day. It just cost about 450 rupees. We were able to present it, won the best paper award. So all I'm saying is it starts with a simple research question. Is there a difference in and doesn't cost much. So simple research can be
Yes.
done. And that's what we really need to, prioritize, giving ourselves a research attitude. And that is, that really should start at a very young stage. I think we've, had Dr. G.V. Rao for long enough.
And he has left, sir. He had an emergency.
Yeah, and had to.
He has left.
I understand. So I'm going to leave closing comments with Dr. Sangram Biradar and Dr. Sagarad to wrap up the whole thing.
Yeah. I request Dr. Suresh for his closing comments and the vote of thanks. Sir. Yes.
Thank you very much. Thank you very much, Dr. Sangram sir. He is the actually academic torchbearer of API Karnataka, and he has been organizing these kind of webinars continuously on a regular basis. Thank you very much. And today's session has been extraordinary. As I put it in my chat box initially, Dr. G.V. Rao, the speech was actually a motivational or inspirational talk for younger lot. There were many people across India joined in this program, and we are very thankful to all of them. And special thanks to Dr. P.S. Shankar, Dr. Roy, and Dr. Jyotirmoy Paul for their inaugural comments. And also, we had a wonderful moderator, Dr. Murali sir. He is now the PRF Karnataka chairperson, and we expect a lot of activities in a research area in the next coming 2 to 3 years. We are expecting a lot from him, and he is one of the best suited for this PRF. And especially we thank Dr. Muruganathan and Jyotirmoy Paul, who API central team, which has been actually spearheading the PRF activities. And rightly, they announced that from November 7th to 14th as a research week in India. And 7th is the C.V. Raman's birthday, and 14th is the World Diabetes Day, the invention of insulin. I thought it can be extended to 21st November because that is the death anniversary of C.V. Raman. So from birth anniversary to death anniversary would have been 2 weeks time. That would have been an interesting thing to celebrate. But anyway, they were restricted to 14th. We can extend it later. So I'm thankful to all the panelists, Dr. Ravindran and Dr. Kushal Das, who took all the questions and answered all our queries, and actually inspired us to do research activities in future. So thank you one and all. It's been a very wonderful session for last 2 hours. API Karnataka will continue to do such programs under the leadership of Dr. Sangram and Dr. Murali Mohan subsequently. Thank you all. Thank you one and all.
Thank you.
Thank you, sir. Thank you. Good night, one and all. We'll sign out.
Good night, everyone.
Thank you. Great session.
Thank you, Dr. Sir.